Assalamu alaikum to students. Today we will discuss the biomechanics of the sacral spine. The structure of the sacral region of the sacral spine. Sacral vertebra that is made of 5 vertebrae, and all of them they are fused to each other and they make a triangular wedge-shaped structure which we call as the sacrum. So as there is no disc between these vertebrae and all these vertebrae they are fused to each other, that's why and somehow we can't consider them as a separate vertebrae. These 5 sacral vertebrae they are also called as 5 sacral segments. The base of the triangle, the sacrum is made of 2 parts, which is the base and the apex. The base of that triangle of that sacrum, and that is formed by the first sacral vertebra. It means the base is the top of this sacrum. So this is formed by the first sacral vertebra, and that articulate with the inferior facet of the vertebra through 2 articular facets. While the apex of that triangle of the sacrum, that is formed by the 5th sacral vertebra, which articulate with the coccyx. This is the interior view of that sacrum. There are 5 segments. This is the segment 1. This is 2, 3, 4, and this is the 5th one. This is called as the base of the sacrum, and this is the apex of the sacrum. These structures, open flat structures, they are known as the ala, which are also known as the sacral wing on both sides. And here where there is articulation with the 5th number vertebra, which make the lumbosacral joint or the lumbosacral segment. This area, which is there is a small projection and in the interior direction, that is actually known as the sacral promontory, and this is the interior superior margin of the first sacral vertebra. This is not only interior, but it is also superior. While these are on the posterior surface, these are the 2 articular processes which make joint with the inferior facet of the 5th number vertebra. These 4 foramina on the both sides, they are called as the interior sacral foramina, and these sacral foramina, they provide exit point for the sacral spinal nerves. This is the structure of the coccyx. There are 4 segments of the coccyx, and this is the first one, second, third, and 4th one. In some people, the coccyx is made of 3 segments as well. These small projections, these are known as the transverse ridges, which actually this is the landmark between the 2 segments. So the first segment, this is the end of the first segment, and this is the start of the segment. So this is actually that replacement of the disc which is present between 2 vertebrae. Here, this is that ridge. So this is the first segment, the second, third, 4th, and then the 5th one. So these transverse ridges, they mark the points of fusion of the 5 sacral vertebrae. This is the posterior view of the vertebral canal. This is the sacral canal, which is in the continuation with the vertebral canal. These are the facet, concave facet. Here the convex facet of the 5th vertebra that will make articulation with this. These are the facet of superior articular process. These were the ala, which were discussed in the previous slides. These water drop shaped structures, these are known as the spinous tubercles, and these are the spinous process of the fused sacral vertebra. While this continuation, small, thin, thread-like structure, which is between the 2 tubercles, this is known as the median sacral crest, which mark the dorsal midline as well as the fusion of the spinous process of the sacral vertebra. So this is the medial sacral crest. This is the medial sacral crest. These are the two crests. One is the medial crest, and there are other crest as well. One crest is that one, and other crest is this one. These two are known as the intermediate and the lateral crest. So this long one, this is known as the intermediate sacral crest, and this one is known as the lateral sacral crest. And these crests that serve as attachment for the muscle and ligaments. There are 4 foramina opening on the posterior side as well. These are known as the posterior sacral foramina, which allow for the passage of the sacral spinal nerve. This point is known as the sacral hiatus. This is the terminus of the sacral canal. This is the posterior view of the that coccygeal, and these two structures, these are known as the coccygeal cornu. Cornu mean horn, which so we can also call as the horn of the coccygeal. While these two are known as the sacral cornu or the horn of the sacrum. So this coccygeal cornu, they articulate with the sacral cornu to provide soft tissue attachment points. The same description for the sacral cornu or the sacral horn. The sacroiliac articulation. There are two sacroiliac articulation on the both side, right and left side. The articulation between the sacrum and the ilium. The two sacroiliac joints consist of the articulation between the left and right articular surfaces of the sacrum. And these articular surfaces, they are made of the first, second, and third segment. So it means the last two segments, the distal two segments, the fourth and fifth one, they have no such contribution in this articular surface of the sacrum in the SI joint. And on the other side, on the lateral side, the left and right iliac bones, they make the articular surfaces. The SIJ having unique characteristic that it changes in structure and function from birth to adulthood. This is the ilium on the both sides, and this is actually that sacroiliac joint. So here it is the first, second, and third vertebra which make contribution to the sacroiliac joint, while the fourth one and the fifth one that have no such contribution to the sacroiliac articulation are the sacroiliac joint. These two are the superior sacral facet which we discussed in the previous slides. Now we will discuss the two surfaces, the sacral articular surface and the iliac articular surface. We will also discuss that what changes they occur at the sacral articular surfaces and the other sacral articular surfaces, the iliac articular surfaces from that birth to the adulthood. The sacral articular surface, they are C-shaped and are located on the lateral surface of the fused first, second, and third sacral vertebra, lateral to the sacral foramen. The fetal and pre-pubertal surfaces, they are flat and smooth, whereas the post-pubertal surfaces, they are marked by depressions that spread all over the articular surfaces. So that is that change which is from that birth till the adulthood, that in the childhood, in the pre-pubertal and the fetal life, the articular surfaces, they are smooth, while after the puberty, then the changes is there are depressions throughout the articular surface and the sacrum. This is that C-shaped articular surface. This is that interior superior projection, which is called as the sacral promontory. This is the body of the first sacral vertebra. The iliac articular surface, they are also C-shaped. They both are correspondents with each other. And first decade of life, that is the first 10 years, the iliac joint surfaces, they are smooth, just like the articular surfaces, and they are flat and covered with the fibrocartilage. But after the puberty, in the adulthood life, throughout in life, the joint surfaces that develop a central ridge that extend throughout the length of the articular surface and correspond to the groove or the depression on the sacral spine. So the point here to remember is that in the adulthood, the changes in the iliac articular surface is from that smooth and flat surface to that development of a central ridge, and in the sacral surface, the changes from the smooth and flat surfaces to the groove and depression on the that sacral surface. So this is that iliac bone. These are the ligaments of the sacroiliac joint, which we are is the EU lumbar ligament, the lumbosacral ligament, and these are those specific ligaments which are providing stability to the sacroiliac joints. These are the anterior sacroiliac joints, the sacrospinous ligament, the sacrotuberous ligament. And there are some other ligaments on the posterior side which are known as the posterior sacroiliac ligaments, and they are divided into two: the short and long posterior sacroiliac ligaments. These are the sacrotuberous ligament and the sacrospinous ligament. The lumbosacral angle, this angle is determined by drawing one line parallel to the ground and another line along the base of the sacrum. The angle which will increase as the pelvis tilts anteriorly and decreases as the pelvis tilts posteriorly. The optimal lumbosacral angle is approximately 30 degrees. As the lumbar lordosis increases, the angle increases. And if there is decrease in the lumbar lordosis, there will be a decrease in the angle. Similarly, if there is interior tilt, and there will be increase in this angle. And if there is posterior pelvic tilt, then there will decrease in this angle. Because with the anterior pelvic tilt, there is increase in the lordosis. So increased lordosis, there will increase this angle. So we can say that the anterior pelvic tilt as well as the increase in the lordosis, they both will lead to the increase in the lumbosacral angle, and vice versa for the that posterior pelvic tilt and decrease in the lordosis. This causes the shearing stresses of the L5 and S1 to increase. Forward movement of the L5 and S1 is prevented by ligamentous support. The shape and fit of the inferior articular process of the L5 inside and behind the superior articular process of S1. Conversely, as the lumbar lordosis decreases, the lumbosacral decreases, as we discussed in the previous slide. So this is that lumbosacral angle, that is a horizontal line, and this one is on the base of the first sacral segment or sacral vertebra. This angle is known as the lumbosacral angle. This is the increase. When there is increase in the lordosis, there will be increase in angle. When there is a decrease in the lordosis, there will be decrease in this angle. Similarly, if there is anterior pelvic tilt, it will lead to the increase in this angle. And if there is decrease in the pelvic tilt, there is posterior pelvic tilt. So there will be decrease in angle, while anterior pelvic tilt will lead to the increase in the lumbosacral angle. The kinetics of this sacroiliac joint. Sacroiliac joint permits small amount of motion just because the groove and the sacral surface and that ridges on the iliac surface, they just fit with each other, and hence there is very little movement between these two surfaces. The SIJ are closely linked with the symphysis pubis. That's why the movements occur at SIJ are accompanied by the SP joint and vice versa. SP joint means symphysis pubis. The plane articular surface in early childhood allows gliding movements in all directions. However, after puberty, the shape of the articular surface are changed so that movement's quality also changes, and then the movement and the changes, because of the changes, the movements become very less because of that depression and ridges on the both surfaces. Nutation and counter nutation occur at the sacroiliac joint. Now, what is nutation? Nutation is also known as the sacral flexion, and this nutation occurs when the base of the sacrum, which is on the superior end, that moves interiorly and inferiorly. This will cause the inferior portion of the sacrum and the coccyx to move posteriorly. The pelvic outlet become larger. We will discuss that what we mean by the pelvic outlet. The pelvic outlet can be described by drawing a line from the tip of the coccyx to the bottom surface of the pubic symphysis. While the counter notation, this is also called as the sacral extension, that refers to the opposite motion. The base of the sacrum moves posteriorly as well as superiorly, which will cause the coccyx and to move interiorly, the tip of the coccyx to move interiorly. The pelvic inlet become larger. The pelvic inlet can be described by drawing a line from the base of the sacrum across the top of the symphysis pubis. It means when there is counter notation, there will be increase in the pelvic inlet, and when there is nutation, there will be increase in the pelvic outlet. So, the pelvic outlet increase with nutation, while the pelvic inlet increase with counter nutation. So this is the nutation and counter nutation. When there is sacral flexion, that is known as nutation. When there is sacral extension, that is known as the counter nutation. This is the explanation of the pelvic inlet and pelvic outlet. This is the sacrum. These are the 5 segments of the sacrum, or the 5 fused vertebra of the segment. This is 1, 2, 3, 4, and 5. If we draw a line from the top, the superior end of the S1, or we can say that from the sacral promontory, a line is drawn to the upper surface of the symphysis pubis. This opening is known as the pelvic inlet. Now, if there is interior and inferior movements of this S1, so that means this distance will be decreased. At the same time, the coccyx that will move posteriorly as well as superiorly, hence the pelvic outlet will be increased. During the counter notation, when there is superior movement and posterior movement of the S1, so that will move in that direction, it will lead to the increase in the pelvic inlet. And when there is posterior and superior direction of the S1, the coccyx will move interiorly as well as inferiorly, and that will lead to the decrease. Eventually, there will be pelvic outlet decrease. So pelvic outlet is the line drawn from the lower pole, or we can say the lower end of that symphysis pubis, lower border, and to the tip of that coccyx. This is known as the pelvic outlet. The area of the pelvis between the pelvic inlet and the pelvic outlet, this is known as the true pelvis, while this one is known as the false pelvis. This is the true pelvis, and this is the false pelvis. This is that pelvic inlet. That was the end of that biomechanics of the sacral spine. Thank you so much to all of you. Have a nice day. Allah Hafiz.